Now let's look at CD4 T cell turnover. Your body is constantly producing new CD4 cells. Even in healthy individuals, all immune cells die and new ones replace them. During HIV infection, this turnover becomes much faster. The virus destroys CD4 cells, the bone marrow and thymus work harder to replace them, but eventually HIV wins the race. The rate of destruction exceeds the rate of replacement. As the CD4 count steadily declines, immune function deteriorates, and that's how that happens. That's how the CD4 T cell turnover works. Let's look at immune exhaustion. So HIV doesn't just reduce the number of immune cells, it also affects how well they work. Persistent viral replication keeps the immune system activated for years. At first, this constant activation seems helpful, but eventually immune cells become exhausted. Imagine asking someone to work every hour of every day without rest. Eventually, even the most dedicated worker burns out. The same concept applies to CD8 T cells and other immune cells during chronic HIV infection. This phenomenon is known as immune exhaustion. Let's look at chronic inflammation. So, chronic inflammation. Even when patients feel well, untreated HIV causes ongoing inflammation throughout the body. This chronic inflammation contributes to cardiovascular disease, kidney disease, neurocognitive impairment, and accelerated aging. In other words, HIV is not just an infection. It is also a chronic inflammatory disease. Let's look at the natural history of HIV. Let's follow the typical course of untreated HIV infection. So, what is stage 1? Stage 1 would be acute infection, which happens immediately after infection. In this stage, HIV replicates rapidly. Viral load rises dramatically. Patients may receive fewer sore throat. Patients may experience... Thank you, Siri. Patients may experience fever, sore throat, rash, enlarged lymph nodes, and fatigue. Many mistake this for influenza or glandular fever. So during this phase, viral load is extremely high. As a result, patients are highly infectious. Here's a clinical pearl. This is one reason acute HIV infection contributes significantly to transmission. Many people don't yet know they're infected. So stage 2, let's look at stage 2. The immune response. Fortunately, the immune system responds quickly. Natural killer cells and CD8 cytotoxic T cells begin destroying infected cells. Antibodies are also produced. As a result, viral load falls substantially. But notice, it never reaches zero. HIV is not eliminated. Let's look at the viral set point. After the initial battle, viral load reaches a relatively stable level called the viral set point. This presents a balance between viral replication and immune control. The viral set point differs between individuals. Some people maintain a very low viral load. Others stabilize at much higher levels. But here's a high-yield example. The viral set point is one of the strongest predictors of disease progression. Higher viral load equals faster CD4 decline. Let's look at the immune escape. So why doesn't the immune system simply eliminate HIV? The answer? Quite simple actually, evolution. Remember that reverse transcriptase makes frequent mistakes. Those mutations constantly generate new viral variants. Some variants escape antibody recognition because GP120 changes shape. Others escape CD8 T cell recognition. These are called escape mutants. The The immune system destroys yesterday's virus, but today's virus already looks slightly different. Here's an analogy. Imagine trying to catch a criminal who changes their appearance every single day. That's what the immune system faces. Let's look at its progression to AIDS. As the years pass, CD4 counts continue to fall. Eventually, the immune system can no longer control infections that healthy individuals eliminate easily. Patients become susceptible to opportunistic infections and certain cancers. At this stage, HIV infection has progressed to acquired immunodeficiency syndrome, or AIDS. So why do people progress differently? Interestingly enough, not everyone follows the same course. Elite controllers. What are elite controllers? So elite controllers are a very small group of patients who can naturally maintain undetectable or extremely low viral loads without taking ARV therapy. These remarkable individuals are known as elite controllers. Their immune system suppresses HIV far more efficiently or more effectively rather than most people. Studying these patients may help researchers develop future HIV cures. Let's look at long-term non-progressors. Another group known as long-term non-progressors maintains CD4 counts above 500 cells per microliter for more than 10 years without treatment. Although HIV is still present, disease progression is unusually slow. Rapid progressors, at the opposite extreme of rapid progressors, these individuals experience a rapid fall in CD4 count and may develop AIDS within just 3 to 5 years if untreated. So at the opposite extreme of the elite controllers are the rapid progressors. And these individuals experience a rapid fall in CD4 count and may develop AIDS within just 3 to 5 years if untreated. Here's some high-yield exam tips. The most important predictors of HIV disease progression are viral load, which is number 1, and another one which will count as number 2 here is CD4 T cell count in individuals. So high viral load and low CD4 count indicate faster progression and a greater risk of AIDS. To summarize, let's recap what we did in today's lecture. So what we learned is that HIV primarily targets CD4 T helper cells, the coordinators of the immune response. Some infected cells produce large numbers of viruses and die, while others become latently infected. This forms long-lived viral reservoirs that make curing HIV extremely difficult. As infection progresses, CD4 cells are destroyed faster than they can be replaced, leading to immune exhaustion, chronic inflammation, and increasing susceptibility to opportunistic infections. The natural history of HIV begins with acute infection, followed by the establishment of a viral set point, gradual immune escape, and, if untreated, progression to AIDS. Finally, disease progression varies between individuals, ranging from elite controllers and long-term non-progressors to rapid progressors. Now, everybody's favorite part, exam questions. Let's look at a possible exam type question, question 1. Which immune cell is the primary target of HIV infection? Is it option A, neutrophil, option B, lymphocyte, option C, CD4 T helper cell, or option D, natural killer cell? And the answer is option C, CD4 T helper cell. Question 2. What is meant by post-integration latency? Is it option A, HIV replication stops before entering the cell? Option B, viral DNA integrates into the host genome but remains transcriptionally silent. Option C, HIV cannot bind to the CD4 receptor. Option D, HIV is destroyed by antibodies. And the answer is option B. And what was option B? Viral DNA integrates into the host genome but remains transcriptionally silent. What is... Okay, for question 3. Why is the latent viral reservoir the major barrier to curing HIV? Is it option A, reverse transcriptase cannot be inhibited? Option B, latently infected cells do not produce viral proteins, making them invisible to the immune system and unaffected by current ART? Option C, protease becomes resistant to drugs? Or is it option D, HIV cannot infect memory T cells? And the answer is option B. Let's look at question 4. What is the viral set point? Is it option A, the highest viral load during acute infection? Option B, the lowest CD4 count before AIDS developed? Option C, the relatively stable viral load reached after the initial immune response, reflecting the balance between viral replication and immune control? Option D, the viral load after starting ART. Question 5. Oh wait, the answer. The answer is C. Question 5. Which two measurements are the strongest predictors of HIV disease progression? Is it option A, white blood cell count and hemoglobin? Is it option B, viral load and CD4 T cell count? Option C, platelet count and CRP? Or option D, viral mutation rate and age? And the answer, it will be option B, viral load and CD4 T cell count. Alright, fantastic work. You understand now not only how HIV infects cells, but also how it gradually weakens the immune system and why the disease progresses so differently between individuals. In our next lecture, we'll shift our focus to HIV transmission and prevention. We'll do that and we'll discuss the different routes of transmission factors that influence transmission risk, the principle of undetectable equals untransmittable, natural transmission bottlenecks, and why modern public health strategies have dramatically reduced HIV spread. I'll see you in the next video. Best of luck. Bye. Welcome back. So far in this series, we've answered two important questions. First, what HIV is made of, and then how HIV replicates inside a CD4 T helper cell. But today we're going to answer perhaps the most important question of all. How does HIV actually make people sick? Why does a virus that initially infects just a few cells eventually leave someone vulnerable to infections that a healthy immune system would otherwise normally eliminate with ease? We'll also explore why some people progress to AIDS within just a few years, while others can live for decades without treatment. By the end of this lecture, you'll understand the natural history of HIV infection, the immune response, viral reservoirs, immune escape, and the fascinating concept of elite controllers. Let's begin. So let's look at the primal target. What is the primal target? The primal target is CD4 T cells. Before we can understand the HIV disease, we first need to understand the importance of its favorite target, the CD4 T helper cell. Think of the immune system as an army. Every army needs commanders. CD4 T cells are those commanders. They don't kill they don't kill bacteria or viruses directly. Instead, they coordinate the entire immune response. They coordinate the entire immune response because they activate B cells to produce antibodies. They stimulate CD8, cytotoxic T cells to destroy infected cells. They recruit macrophages and other immune cells to sites of infection. Without CD4 cells, the immune system becomes disorganized. Imagine trying to run a hospital where every doctor, nurse, and paramedic is present, but there's no communication or leadership. Of course, chaos will follow. That's exactly what HIV does. Rather than attacking every immune cell, it attacks the one responsible for coordinating them all. Productive infection. What is productive infection? When HIV infects an activated CD4 cell, the virus completes its replication cycle. The cell becomes a virus factory. Thousands of new viruses are produced. Eventually, the infected cell dies. This is known as a productive infection because the infection results in the production of infectious viral particles. Every productive infection destroys another CD4 T cell. Over time, millions of CD4 cells are lost. So what's the clinical correlation? What is the clinical correlation? This progressive loss of CD4 cells explains why untreated HIV gradually weakens the immune system. That will lower the CD4 count, the greater the risk of opportunistic infections and certain cancers. Post-integration latency. What is the post-integration latency? Let us have a look. Not every infected CD4 cell immediately becomes a virus factory. Some infected cells enter a very different state. Remember from our previous lecture that HIV integrates its DNA into the host genome? So sometimes that viral DNA simply remains silent. No viral proteins are produced, no new viruses are made. The infected cell looks completely normal to the immune system. This is called post-integration latency. So why is latency so important? This is one of the reasons HIV is so difficult to cure. The immune system can only recognize infected cells that are actively producing viral proteins. Latency infected cells remain hidden. It's like a spy living undercover for years without revealing their identity. Alright, here's a high-yield example. So latency infected CD4 memory cells form the viral reservoir, which persists even in patients taking effective ARV therapy. So ARV, as you know, antiretroviral therapy. The permanent viral reservoir. Let's look at that. So one of the most remarkable and frustrating features of HIV is how early these viral reservoirs are established. Research has shown that HIV can create a permanent reservoir within approximately 72 hours of infection. That means, what does that mean? That means by the time most patients even realize they've been exposed, the virus has already hidden copies of itself inside long-lived memory T cells. These cells can survive for years, sometimes even decades. This is why antiretroviral therapy can suppress HIV but cannot completely eliminate it. Analogy is an analogy. So think of a wildfire. Antiretroviral drugs are excellent at putting out the flames. But if hidden embers remain underground, the fire can reignite at any time.